calling us for this discussion. Me and Satish are going to go through a series of cases related to intertrochanteric fractures, and hopefully we get some message at the end of the day. So that's my first case. It's a common problem faced in non-unions of intertrochanteric fractures which have been treated for a long time. This is a lady who was operated 4 years ago. She's 61 years now when she presented to us. She was walking till a point of time some months ago when she fell down again, and she had this problem. She also has pre-existing severe arthritis of the knee. She's 61. There is a fracture at the intertrochanteric and a subtrochanteric level with a broken implant. The question to you is whether you would follow a late salvage or whether you would do a fixation. What would you do for this is the question. Where's my panel?
Panelists are there in the front row.
Okay.
Karkhanis sir.
Okay.
And Sangeet, where's Sangeet gone?
So all right, let's put the question to the panel. Karkhanis sir, what would be your option of treatment?
So that this patient has again fallen down.
Yes.
How old is she? 61.
61.
Yeah.
She was walking till the time 2 months ago when she had a fall again, and she had this kind of a picture. We don't have the pre-op x-rays because all this has happened outside of the city. She's come to us at Cooper with this picture.
Harshad, your panelists are Dr. Gawale, Dr. Karkhanis and Dr. Shahane. Yeah?
Yes, sir.
Okay. So she has got these implants, and I think it's difficult to pass any other implant because there is a implant in the neck and head of the femur.
Yes, sir.
So I think I would go for a replacement in this case.
So here, how difficult would it be, or how easy would it be? Because the entire proximal portion is the part, the GT is the LT, all these are part of the proximal fragment. Distally, you have only the shaft which is there.
Arshad, may I ask
Yes,
a question
sir.
before
Yes,
we proceed? In presence of severe arthritis of the knee, do you feel that the failure of fixation is high because it leads to a varus bending moment? I asked the panelist. I'll show you a case also.
Yes.
Whether you do a fixation or a arthroplasty. Okay. So does it affect? Do you insist on this patient to undergo a knee arthroplasty after your fixation?
All right. So that is the arthroplasty surgeon giving his opinion. Sangeet sir?
He'll come, he's next after you.
Yeah.
We'll stay in salvage fixation now.
So two options, either salvage
Yes.
or replacement.
Yes.
As he said, if you want to salvage this, you have to load the construct. You have to load the limb.
Yes.
And I don't think with the knee, she will not be able to do that. However, the quality of the cortical thickness of the femur is not that bad, except what looks in the head. In spite of osteoporosis, in spite of pinea or osteoporosis, the helical blade has not shifted.
Yes, sir.
That is one thing. Second is, she had an intertrochanteric with subtrochanteric, and probably it has failed at the subtrochanteric level with the implant breakage. Considering her situation, I would opt for a replacement where the large greater trochanter, I would fix it with a plate, trochanteric hook plate, and load her as early as possible.
So you would do an osteotomy of the neck separately?
Yes, yes.
And keep that intervening
Yes.
fragment as your proximal
Right.
metaphyseal
And
wedge.
use the head as a graft.
Shahane sir, you have another opinion on that?
I think I agree with Sangeet. Trying to fix this again, considering the degree of comminution and the osteoporosis, you are looking at another failure of fixation.
Anybody for fixation and
And
everybody?
what is important is what Sangeet said,
Yeah.
is to maintain the greater trochanter and get that abductors back with a hook plate. Okay, just replacing will not serve the purpose.
Yeah, so anybody for just fixation? Yes, Sudhir sir.
See, in spite, if you see the X-ray, the head doesn't look avascular. It is not a TC fracture. It's a type of trochanteric extending into the subtrochanteric region. And the bone quality is very good. In spite of that, the head, the screw is centralized. It has not eroded your neck. So you have lot of space to put a implant. So I'll fix the this femoral fracture. Probably add a lateral plate also.
So what kind of implant do you want to use when you're
I
fixing?
can repeat this same implant with a lateral plate.
So you'll put a PFN again?
PFN or a angular blade plate.
All right. Sir, Pradeep sir.
Uh, I think this patient, I will do total hip and total knee and see that patient walks as early as possible. Because first, if you try to do osteosynthesis, it's subtrochanteric, very unstable, biomechanically very unstable, chances of failure of very high. So both should be done, and the best treatment for osteoporosis is make the patient walk on normal alignment. So
Abhijit?
both replacement is the best option.
Abhijit.
So the joint is not arthritic and neither is the head in AVN. So if we want to do a salvage hip arthroplasty, it will be an extended indication. So we'll try to fix this fracture. The options available are either use a surface implant or an intramedullary implant. It's easier to correct and maintain the angle with a surface implant compared to a hip implant. The choice of implant would be 95 DCS or an angle plate.
Right. Now, Harshad, now I would like to move on.
Yeah,
We've got
sorry.
our cases to cover.
So what I did, of course, so these are the CTs, of course they are not material. So in lateral position, the implant removal was not a problem, it just walked out. I used an angle blade plate to get the valgus angle back, and I have augmented the GT with a tension band wire. It's not a perfect valgus angle, there is a little bit of varus still there, and I had not bone grafted it because there was adequate bone around that area. I didn't specifically graft it, I've just gotten the angle. And this is at the end of 4 months. She's walking. She was non-weight bearing for about 6 weeks, and then we started weight bearing. And this is at the end of about 8 months. She's full weight bearing now. Knee is a problem, which we will tackle at a later on date. Any comments, any suggestions, any alternatives?
She's walking on the implant.
If you don't replace the knee, lot of load is going to come on the implant. And
Sangeet
that might
feels the
give way.
fracture is not healed as yet.
Harshad, are you happy with
She's
your
walking
union?
on the implant.
You
I
feel
don't
it's
think
not
your
healed as-
knee is worrisome because of valgus deformity. So it's not going to put a VORA stress on your implant up here. You can easily wait till the bone heals and you are comfortable,
Yeah.
the patient is ready. So knee, I don't think should matter at all because of valgus deformity, not a usual varus.
Yeah. So you mean the knee is now loaded centrally because of the knee valgus which was there initially?
Are you happy with the union?
The union part,
Or
she's
as
comfortable.
Sangeet-
See,
as
I get
Sangeet
your point.
said, is he still walking on the implant?
Yeah. I get your point as far as the healing is concerned. Yes.
I think patient is not fully weight bearing, functional. TKR is must, and I don't think it is united completely. Osteosynthesis is not complete.
All right.
Yes.
Any further
Sangeet,
follow-up,
these-
Harshad, or should we move ahead?
The issue with these implant is you don't see a good callus or a good union.
For a long time.
Radiological
Yeah.
union, you see it at the end of 1.5, 2 years. You don't see that early.
So it's too
So as
early
long
to
as-
label it non-union.
But the empty hole there probably is issue.
The one okay, fine,
second
fine.
hole,
Understood.
which is at the
Understood.
subtrochanteric level.
Okay. Okay, the next case.
Thank
Harshad,
you.
any further follow-up or we go to the next one? Okay. Now, Satish.
So this was just another case which is linked to the first one. Let's not go into that. Let's go for Satish.
Thank you, Harsha. So this is a young person with this done about 8 months back. 8 months back somewhere else, and I have seen it at the end of 8 months. Yeah. 48-year-old guy, close PFN. I don't have the initial immediate post-op and the pre-op, but this is at 8 months with a painful hip.
Sangeet, your opinions?
The issue is why it has failed. So it was a basal fracture. Above, both the trochanters are intact. Probably one. Second, your entry point, it is through the trochanter. Now, still, what is the age of the patient?
48.
48. There is a good bone in the inferior part of the head, which you can use to put any implant, and use a combination of nail and plate here, because it is very likely in the attempt to remove the implant, you will break the lateral wall.
So see, we heard a lot about osteotomies in your talk with different implants.
They were called intracapsular. This is extracapsular.
Yeah. So I think today, through this case, we should have a consensus take-home message that when we are doing an osteotomy for this case, what should be the choice of implant? Because today you don't get the earlier double angle and implant. So today, what would implant would you use? 95?
I would remove this implant and use a 95 degrees. What is the question of doing an osteotomy over here? This is a non-union. We are talking about those cases of fractured neck femur where there is a non-union where you require an abduction
But
osteotomy.
will the fracture correct just on the implant? I mean, you think it's a fully mobile fracture at 8 months?
Yeah, it is because it has cut out on the upper side. I don't think there is a lateral to see where that implant was there. Maybe it is in the superior.
Satish.
When you remove the implant, the virus will get corrected.
Yeah, I think the main problem is, as Sangeet pointed out, this was basically a basic cervical fracture. I think an intramedullary implant was not the greatest of choice for these fractures. Second, probably was fixed in varus, not corrected, which is what has led to the failure. Just removing the implant and putting another intramedullary nail, I don't think will correct that varus. And you may have to correlate something what Sangeet has shown us in his previous talk. You may need a corrective osteotomy if you can't correct the varus, and have an additional derotation screw with whatever you use to fix this.
So what would be your choice of implant?
I think just now you just have the DHS type of implant.
95 or a 130?
Satish,
No, the 120.
the best is like after you remove the implant,
Fill
how
the
much
gap.
is the mobility, how much you can mobilize that non-union will decide your choice of implant and construct.
So this is a
this is a case where that gap of the nail removal should be filled with fibula or some, that is most important, and 95 degrees is the only choice.
This is an attempted adduction view. I don't know how useful it is.
Yeah, can we just stop here? Let's have some, everybody who wants to speak, please put up your hand so that everybody gets a chance to speak.
Yes, Abhijit?
If you look at this fracture, this is a basic cervical fracture extending into the greater trochanter. We call it as a basic trochanteric fracture. The second problem you see here is the neck is medialized. So this is a negative reduction. And this has gone into a varus failure. Now you can very well treat it with osteotomy using a surface implant or an intramedullary implant. If you are using an intramedullary implant, you will have to lateralize that fragment. You will have to go for a positive reduction. If you are unable to get that on the table, you may shift back to the surface implant and fix it with a 95 DCS.
So do we conclude that for basic cervical fractures, a PFN is a big no? Or you can still do a PFN for a basic cervical?
You have to do the BFN which is absolutely accurate. It has to be center and the tip apex distance should not be more than 20. Just short of that. It has to be in the center. Second point is that the medulla, you cannot have a loose nail in the medulla. It has to have a grip because that is the working length of the implant. Otherwise you put a long implant.
The problem with this fracture is you need a second screw, a derotation screw, because the head spins on that because it doesn't have any trochanteric attachment.
Dr. Mohan Desai sir wanted to say. Okay, so this is what we plan to salvage it. This is removal of the implant. This is after we have actually used, sorry? So it's only now, we have done osteoclastic after removing the implant. Then we used, this is a 95-degree guide pin. That's a wire broken inside, just ignore that. This is a DCS. Now I would have used an angle blade plate. This is a DCS. This is a open wedge osteotomy. This earlier when I did osteotomies, they were all open wedge osteotomies. So this is an open wedge osteotomy. You use a 135-degree implant so that 95 gets converted to 135. And this is the immediate post-op X-ray. Not much of bone grafting. A little bone graft from the GT is, I used to put it there. This is the immediate post-op X-ray. This is the So the sorry?
Can you go
As a
back to
95?
No, no, can you go back to the slide? That is not a 95-degree entry, Satish. Yeah, guide wire. Guide wire, previous. Yeah. So your
a 95
entry has to be at just below the tip.
It is at the level of the vastest ridge.
No, 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 no. This is 110 degrees entry.
I think whatever it is, 110 or 95, you have passed a guide wire which is not 135.
Yeah.
And that's what I was saying in the previous, what I told Sangeet, that you can pass a guide wire at 110 or so, and you have put a 135 degrees DHS. So you don't have to bend the DHS, you don't have to do anything there.
No, sir. See, no, 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 no.
Yeah, so this is the initial cases where lending became a problem.
Okay, Satish, we move forward.
Anyway, you have a post follow-up?
Yes, sir. This is 5 years follow-up. It's healed, all fine. There is a lengthening of 1 centimeter, but patient is fine.
I think the outcome is good. I think that
The
you
open-
must follow this, that you pass the guide wire at 110 or maybe 100 with a goniometer and put a 135 degrees DHS. So you get a correction of about 25 degrees. So you don't require that 120 which is not available. And you don't have to bend the plate where it becomes weak.
So these open wedge osteotomies, I think for beginners, they're very easy. That's how I also started learning. You just have to make a single osteotomy and bring the shaft to the plate, and the plate does the whole correction.
The advantage of using a 95 DCS contoured to 120 degree over a DHS is to get an additional screw in the proximal fragment, which gives you a rotational stability.
Yeah. So double angle implant definitely has advantages, but it's a little more demanding. This is easier to start.
Great, Satish. Can we move on to the next case, please?
So this is a 85-year-old female. She's the doctor's mother. We've done a PFN for her. Did a long PFN because she was homebound, mobile. She was walking before the fall. The only thing which was there was the greater trochanter was also broken. It was moved out. And then while reduction, after the fixation, it came back in place. Now this is the post-op fixation. Are we happy with this?
The fracture is exiting through the piriformis fossa. This falls in an unstable fracture and
Yes.
is an indication for a dual implant.
You
Do you
want to
have
put
pre-op
a-
X-ray?
You want to put a lateral plate also? Yes.
Do you have pre-surgery X-ray?
Sir, I just don't have. I'm so sorry. I don't have the pre-surgical X-ray. That's what I said. The only thing in the pre-surgical X-ray was GT was slightly off. And once we put in the bolt on the lateral side, we could compress it and the GT fell back in place. Yes.
But it is distracted. Fracture is
Yes.
distracted.
Yes. That fracture is distracted. And another thing which happened, you try and not open the fracture. You do it close. The screw has gone inside the lateral cortex. You just notice that. Yeah. Outside, yeah. So what is the expected? Sir, you said there was a gap, there's a fracture is distracted and you said the screw. What do you expect at the end of it when she starts to weight bear?
Because see, the nail is too deep inside, so therefore it has gone in the medial, this inferior side. You must point for center. That is the most important thing for any PFN.
Center, if you don't get center, inferior center is also fine.
Inferior and
Yeah, but
okay.
Arshad,
Yeah.
if you're using a spiral blade, this is one of the common complications.
Yeah.
Is joint penetration.
Yes.
So you need to stay a little away
Away
than
from
you
the
would if you're using a screw.
Yeah. So what
See,
happened was that GT went in the place where my entry point was, and it blocked the screw from coming out. So that is what happened. As anticipated, 6 weeks later, the screw has now gone inside the joint, and the GT seems to have healed up. And this I had sent to Sangeet. So Sangeet had done these markings on the phone. You can see there is a collapse at the fracture site, and that is what has caused the screw
But the
to kind
screw
of
should have been
penetrate.
locked from the top, is it not?
So no, it is not locked from the top.
So why it was not locked? That is the most important.
So
That
if you
have to
lock it, it
So-
will lock it. It will even penetrate.
How?
It will not allow it to come out, no sir.
Arshad, there are the 10 commandments by Dr. Shiv Shankar.
Yes.
And he clearly mentions that the spiral blade has to back out of the outer cortex of the femur. The
Yes.
moment it goes inside in the endosteum of the femur, when the patient is loading weight, there is a chance for joint penetration.
Absolutely.
Because the endosteal surface of the shaft tries to press on the
So
plate.
that's a very important point made, that the screw length, in order to seat it right inside, just ensure that some part of the screw is left out of the
many
cortex.
times when we are doing a PFN, we are confused about the length. You err on the side of a longer PFN blade than a shorter one, and you'll always probably be
If you
correct.
put a short screw and then you want to put it subchondral, that's where the problem happens. So this is what happens. She's 85-year-old, she's homebound, she's walking. Now she has this kind of a situation. What would you do now?
The joint is penetrated, you have a chondrolysis, you have no option but to go ahead with salvage arthroplasty. Intramedullary, one has to go for a difacial fixing step.
Yes. All right.
Arshad, have you done any other CT scan or anything?
It was
This is
done, I
how-
don't have the
This is
pictures.
how long now since the fracture?
This is now 6 weeks post-op.
Okay. And how bad is the pain?
She's not mobile. She's painful, she's bedridden. She's not moving around like what she was doing for the first 2 weeks of surgery. 3rd week onwards, she started not moving.
I think my choice would, if you keep her in bed 6 weeks more, if the fracture is healed, just do an implant removal.
Implant removal and leave her alone. But it's just 6 weeks since your injury. Okay.
Right, let's move.
You don't want to replace this. Remove and make the patient walk. Okay. Okay.
Yeah, the arthroplasty surgeons are very clear what they will do. their turn will come. That's why their turn will come next.
Okay.
So this
Sangeet
is
sir,
for the
Sangeet wants to
non-arthroplasty
make a
trauma
comment.
surgeons also.
Sir, we got your point. Replace it and make her walk.
I am sitting in between arthroplasty surgeon and the coxofemoral bypass.
Okay. Sorry?
Then
CT was there. I have not put up the pictures here. Sorry. What would you want to see?
6 weeks too early to
6
unite.
weeks.
Pradeep. Too early.
Union is not. I don't think it was united as yet.
Okay, Harsha.
6 weeks. I would not expect it for that.
Journal of Radiology, this was in the radiology group shared, March paper. The earliest you can see a CT scan based evidence of fracture healing is 16 to 24 weeks. Before that, you cannot make any comment. Whether the fracture is healing.
Okay, Harsha, we'll move on in the
Yeah,
interest
so
of time.
what I did was, see, my thought process was different. Her weight bearing area is okay. She's 85-year-old. She's homebound. We need to make her walk. It's too early to remove implant and I don't want to go for an arthroplasty. So what I did was, I removed the original screw. I put in a shorter threaded screw and put in another screw at an angle so as to prevent any kind of toggling effect. And then this time I ensured that the screw is out of the lateral cortex. And that's how I left her. And this was immediate post-op. And this is 3 months post-second surgery. She's now walking. She's using walker support like what she was doing before. And she's healed up now. She's moving around comfortably.
Harshad,
Sorry.
if money was not a problem, I would have changed that and put in a screw in that same hole and locked it so it will not migrate inside.
So if you lock it and the fracture collapses, there is a higher chance of migration.
No, that is not the thing. If it medializes, if the offset is reduced, then it will medialize and it will be short. Either it will come outside or it will go inside. If the shaft is occupied by the nail, it cannot go medially.
Sir, if you lock the screw, you are converting, it's like your old time Jouet, where you had penetration of the joint as a common complication.
No.
If you don't lock it, you at least allow it to slide out.
No, Sunil, there the Jouet nail was outside, the Jouet nail was not inside. If it is outside, it will medialize. If the nail is inside, it cannot medialize, the offset cannot reduce, neither the screw will come out, nor it will go in.
Sir, the medialization of the shaft you're saying is a different matter. What we are talking about is the penetration like that happened in this case when they used the blade.
Correct.
If you lock the blade, there is no way that either the blade or the screw to back out. And
So
if
why
you
you
don't
want
allow
to-
it to back out, and if the kind of pressure, because your screw is short, and your endosteum is pushing on the screw to go through to the joint, it is bound to go penetrate the joint.
So I will not lock it. I will not put a pin to lock it because I feel that will increase your chances of penetration. If If I want the screw to back out, I want it to back out outside of the lateral cortex. So this is what I did. Any other comments on this? So I'll end this case.
So how many would put two screws distally and make it rigid there, or one
Satish,
dynamic
Satish,
screw?
before to your question, I would like to know by a show of hands, how many of you lock the screw as Dr. Karkhanis was mentioning so that there is no collapse?
I would lock it because it is not going to come out, it's not going to come in. It will happen only if the shaft medializes, and the shaft cannot medialize because there is something in the medulla. Whereas in the DHS medialized, the offset became reduced, so either it came out or it went in. Same thing, what happened in the jewett, it's the plate, it's not in the medulla, so it medialized, the offset got reduced, and either it went in or it came out.
So even with the intramedullary nail, the amount of medialization is what is there, the space.
Yeah.
It's only when your neck fragment comes and hits your intramedullary nail that the medialization stops.
Sir, in
So
this
it's not that
Therefore, in this case when they are osteoporotic, I will use nothing less than 12 number. I don't want that nail to toggle inside the medulla.
So in the middle X-ray, if you lock it here, and suppose it's outside the lateral cortex, that collapse will occur, and it will not allow that screw to migrate out, and therefore it will penetrate the joint. That's why whenever there is a gap at the fracture site, whenever there is a little distraction, you should not put in the top, the pin. Otherwise it will penetrate and it will convert it into a fixed angle. If you have a good anatomic reduction, you have a good contact, and there is no hope of collapse, that time the pin will work.
You tell me how the offset will reduce when the nail is inside, you tell me.
So because there is a gap here at the fracture site, between the neck and the medullary canal, there is still a space.
So?
It will collapse, sir. There is nothing to stop it.
It will collapse vertically.
Sir, in this case, because the screw is inside the medullary cavity, it is acting as if it is locked, because it is not getting space to come out.
I think this topic is a hot topic. We'll
Yeah.
continue
We'll-
the discussion later on.
I have never had
So
any
we'll
penetration.
continue the discussion later on. We'll just move on with the next case.
The AO manual says that the locking option is to be used in a young intertrochanteric fracture where there is no medial combination, anatomical reduction, and you hope no further collapse, so you prevent limb line discrepancy. That is AO manual.
Right.
And in
So
old
the panelists.
And in
will
old
distribute.
patients, Satish,
You use the
what
control-
AO is saying?
You use the controlled collapse mode. So there are
No,
three
you lock
modes
it or
in-
you don't lock it. What they are saying?
You lock it
You
in
lock-
the controlled collapse mode. See, there are three modes in the TFN. The controlled collapse mode is where you lock it and then unlock it half a turn. So the screw still slits in the slot, which will allow only axial collapse, but absolutely no rotational force on the head. That is what is recommended in elderly porotic bones. So there is only axial collapse which is required for healing.
And when you fully lock it?
Then there will be no collapse. So somewhere collapse has to occur for healing. Distally you have made it rigid. Proximally if you make it rigid, then the only thing it can collapse is over the screw, and the screw will medially migrate.
The screw will go inside.
Sir, we'll discuss this. Sir,
outside.
sir, to be locking and unlocking of screws at the
Arey,
coffee
but
break.
Girish, this concept has to be very clear. You
Yes,
please
sir.
don't bypass that.
No, sir.
I am saying if it will medialize, it will shorten, it will go inside or outside. With the nail inside, it can't do that. That's what I am trying to tell you. I have never had medialization of anything. And Sunil, one case, it was not locked. The surgeon over here only forgot to lock it, and it got right into the hip it went. One case it happened. I'm not telling
So
who.
such single cases, are there for every surgeon who's been doing THR with every complication. So that you cannot generalize and say
So
that.
how
that
many
is
are,
the reason.
you have said raise of hands, how many raise hands for locking from the top?
Totally 4 people.
And all
Four.
said no, don't lock?
All of them said lock, like you said. Others all said control collapse. So can we just move on, sir? We'll discuss this over the coffee
So
break.
this is a fourth case, a long-standing subtrochanteric non-union. So this is a 48-year-old, 50-year-old guy who presents with a broken implant and a subtrochanteric non-union. It's a very interesting history. He is a 44-year-old event manager, very poor lifestyle, bad habits, heavy smoker, alcoholic. He had a RTA 15 years back. Dr. Gawale sir will remember, you had helped me for this case. So first time he had ORIF with a DCP which broke in 8 months. He's very heavy also. So we did an exchange nailing with a sun nail which broke after 2 years. Then we again nailed it with a thicker nail on which he carried on for 11 years, and after 11 years that broke. Finally we did a blade plate fixation which broke after 6 months. Twice we have done bone grafting, once we have done BMP also. And this is his current situation after 4 surgeries.
So, this last surgery, if you see there is a gap in the medial cortex, and the medial cortex is the weight-bearing column. So, if there is a medial comminution,
sorry, no sir, he's not.
So, if there is a medial comminution, invariably one has to go for a dual implant. All the 4 previous surgeries you have shown are all done with a single implant.
That time we were not talking of dual implant.
Satish.
Yes sir. This is today now, what do we do?
In substrokes, what you cannot have is a varus. And here also, one is it in varus, as Abhijit pointed out, there's medial comminution, so there's loss of the medial column integrity, and I think too rigid a fixation.
So what do we do now? I mean, twice nailed, twice plated.
I think I agree with Abhijit. Now my choice would be remove the implant, remit, put an intramedullary nail, and supplement that with an additional lateral plate with bone grafting.
Right, Satish, we'll have to move on, my friend, because we've got time constraints here.
Okay.
What did you do?
So, this is what our steps. We removed the implant. This is what I have done. Freshened the non-union. We took intra-op cultures for infection, reamed the canal both sides, and I have used a PHLP of Smith & Nephew with Genex bone graft. So first I filled the neck with all the 4 screws, the alpha beta screws, whatever are available, and then actually we did a plate reduction. So you get automatic valgus, used a compression screw distally and then locked it distally. Sorry, there were 6 screws this time. We wanted to put 4, but one was dicey. So this is the immediate post-op X-ray with a PHLP and a Genex bone substance and compressed.
So the only alternative for a dual implant was use a fibula with a plate. The fibula serves as the second implant.
One side fibula was removed second time. He was very unhappy with it, so he refused for fibula. Both iliac crests have been opened. Compression device.
Right. Any further follow-up, Satish?
So this is 10 weeks post-op implant holding fine. We started thoda weight bearing. CT scan 6 months showing patchy healing posteriorly and laterally. We tried this bone marrow injection for whatever worth it is. This is 7.5 months post-op. This is 2.5 years post-op. Patient is walking at the moment comfortable. This is the last follow-up that we have.
So not for the faint-hearted. We move on to the next case by Harshad. Hold your applause. They've still got the jugalbandi ongoing.
So this case I have right from the beginning. This is an intertrochanteric with a subtrochanteric extension. I won't go into modality of fixation. Who will use an intramedullary implant preferred to a surface implant? What would be the ideal choice of implant?
Just a quick show of hands, please.
Surface implant?
Surface implant?
One second. Let's. Surface implant is and intramedullary implant. I think more for intramedullary than for surface. And Jayesh said he wants to use a combination of nail and plate. So what was used was a 95-degree DCS with a calcar screw and a GT wiring with interfragmentary screws for the subtrochanteric area. Who are happy with the fixation? Even I am not happy with the fixation. It's in varus. There is a gap on the medial side. The calcar screw is not really holding the calcar. It is there in the medullary canal. I would have been happy if it were holding that area of the calcar. I don't think bone grafting was done on day 1 because intra-op I think it looked reasonably okay to this. Predictions on success versus failure? It will fail.
Day one failure.
It will fail. Whether day one or not, I don't know, but it will fail for sure.
Harshad,
Yeah.
in such fractures, is there a need for CT scan when there is a combination of the GT to start with?
Yeah, so CT scans were done over here, but they were not relevant as far as fixation is concerned, so I haven't put up the slides. They were done.
So if you look on the day one X-ray,
Yeah.
it's IT fracture with a subtrochanteric extension with extension into the piriformis fossa, which is the indication for a dual implant. And even with a dual implant, this patient take a long time to heal, anywhere between 9 to 15 months.
So the concept of dual implant has come up in the last 1 year, maybe 1.5 years. Till that time, all these cases were before of that point.
So a long PFN nail along with a lateral buttress.
I'll show you one dual implant which I have done after this case.
Yeah, go on, Harshad, go on.
Yeah. So this was done, and obviously this had to fail, which it did. So now what are the options available for you? This is a 54-year-old gentleman.
Dr. Gawale.
Osteotomy, sir.
संगीत सर, आपके विचार.
Why that has failed? Probably the proximal fragment has not been corrected as far as the rotation is concerned, and that is why you don't see a greater trochanter profile in the AP as compared to the other side.
Yes,
So that rotation, poor medial reduction, poor anterior reduction has led to breakage of that implant. What has to be done now? Can you go to the... So you have to correct the varus and use a combination of intramedullary as well as extramedullary implant.
Okay, Harshad,
And
let's
What
go.
have I done?
This is what, okay.
So what I did was the same screw was holding pretty well. I just used the same screw. I've changed it to a 95-degree implant, and I have bent the 95-degree implant. Now there's a disadvantage to this, is that medialization of the shaft, and that creates a problem in the knee, as we have discussed this before. If you have a double angle plate, it will help, but in this case, this was some time ago. So I just put a bent 95-degree angle. I tried to get a hold on the calcar. I couldn't get that because there was a void there, so I had to incline the screw so as to get it into the proximal fragment. The remaining interfrag screws I did not interfere with. This is a very early failure. It happened within about 3 months of the index surgery. This is 5 months post-operative, and this is, he was walking, but as you can see, the knee is in valgus because of the medialization of the shaft. So this is a problem when you bend the angle 95-degree plate. You should try and keep the shaft aligned to the medulla, to the greater trochanter or to the line of the greater trochanter, and not medialize it, because eventually, though the fracture heals, it gives problems as far as the knee is concerned.
Right, lovely. Many ways to skin a cat. Satish, case number 3. Yes, Ashish.
So this is a lady about 7 months post-surgery, long PFN done for IT. I don't have the earlier X-rays. She comes to me at this stage with pain. What should be the further plan? Somebody at the back, yeah.
Anybody having any opinions till we go to the panelists? Somebody said CT, Satish. I could just hear the whisper.
I think there is a virus over here. There is a bending stress. So it by bending strain, I mean, it might fail.
Configuration of fracture. The configuration of the fracture is oblique. That is why in a AP you cannot see the healing. Now, why that has failed? Your entry point is wrong again.
Satish.
Okay. And the varus, the lower screw, the hip screw, is in the center. So whenever you have that, your reduction is in varus. So that has, it is unlikely to have
This appears to be primarily done this way because there is no screw migration evidence.
The fact that she is
Two
painful,
component.
Sorry?
the fact that she is painful, you should suspect a non-healing.
Fractures two components, IT and a subtrochanteric extension.
So could the pain be because of the implant cut out? I mean, if she's a very low demand individual, can you just remove the implant and leave it? No.
Now, how can you confirm that it is united? I mean, you'll have to give us
I'm
something
asking,
to do that.
is that an option? Suppose the CT shows union.
Yes.
Even in that case,
Yes.
is it an option?
Yes. Yes. Okay, go ahead. Satish, let's go ahead. What's the...
So again, we removed the implant. This time we use an angle blade plate. Not here. On a fracture table, once you remove the implant, you could see. So this time it's a closed west osteotomy. The upper edge of the osteotomy is always parallel to the angle blade plate. And this is a lateral closed wedge osteotomy using a 120-degree implant, which is difficult to get, but we got it. And this is the post-op X-ray. Using a 120-degree implant, you use it in the 90 trajectory, 95. So effectively, as sir said, you get a 25-30-degree correction.
So if it is not available, you can use a DHS of 100 degrees and put 135 degrees DHS.
Here you would see that we normally don't drive the blade completely inside, because if you drive it completely inside, then the shaft will get medialized, which will create a biomechanical disadvantage. So you actually always keep it a little out. You keep one size bigger blade plate, keep it out so that the shaft is also lateralized and not medialized.
So this seems to be the flavor of the month, the angle blade plates. I don't know how many of you all have had the experience to do this type of, it's a very good implant, but not very easy to do. So all of you all who are looking at this and say, okay, I'll try it next time, it's not that easy. These guys are very, very experienced and they know what are the pitfalls. So connect with them if you have something which you would want to use this implant. Okay.
So I'll just show one last case. I will not show this introp via breakage. I will not show you this.
Satish, what degree you passed that guide wire? 95, so same.
No, sorry, I don't have that dual implant case.
That's what I've been saying all round, that you put a 95 degrees guide wire and put 135 degrees.
Okay, before this Jugalbandi finishes, we've got about 2 minutes or so. Any questions from the floor to these two very senior trauma surgeons? Yeah, please. The role of LT wiring, if any.
LT wiring is done if your LT is contributing to the stability. If it's an avulsion small fragment which is not having a lot of the distal cortex, then you leave it alone. You don't do anything much about it. But if there's a large lateral posteromedial fragment where the posterior part of the cortex of the distal shaft is along with the lesser trochanter, then try your best to just get it back in position. You need not put it back anatomically, but try and get it back as close to your original position as possible.
Right. Yeah, okay, Gautam, Satish, we've got the present.
Take-home messages from you in terms of how can we prevent these modes of failure? Because what we understood from whatever you've shown today was they were not failed fracture fixations. They were failed surgeon fixations.
Yeah, so
right? So what are the mistakes the surgeons are making, which is making this kind of hip fractures failure so rampant?
If I show this case, all the bad things are incorporated here by me. So this is a subtroch which was fixed. Patient was fine, 70-year-old lady, started weight bearing at 6 weeks, and this is at just 2 months. 2 months, thin lady, not very heavy lady. All the wrong things that have been done in a subtroch here. So 3 principal things is varus. At no cost there can be varus. There cannot be a gap at the fracture site which has been addressed to. And third, you can see n number of screws distally making it a very rigid fixation. So you need to have a sort of semi-dynamic fixation. This is just 2 months post-op.